Hi, I'm Nicole. I'm from the pharmacy team. We were consulted on patient Margaret Bush. She's a 55-year-old female with end-stage renal disease from hypertension and type 2 diabetes. She came to the transplant clinic for her first post-transplant follow-up. She received a deceased donor kidney transplant 8 days ago and was released from the hospital 5 days ago. She reports pain at the surgical site and stable bowel movements, not requiring any pain medication or bowel regimen. When we reviewed her blood pressure and blood glucose logs, we saw her blood pressure ranging from 152/76 to 155/82, with her blood glucose ranging from 85 to 118. She has a past medical history of hypertension and type 2 diabetes and was maintained on medications until 2014 when she was started on continuous cycling peritoneal dialysis. Her native urine output is about 1 liter a day, and she reports having no other complications from her diabetes. During her pre-transplant evaluation, a cardiac catheterization was done, and she was found to have a 90% occlusion of her right coronary artery, which required a drug-eluting stent back in August of 2016. Patient is married and has an occasional glass of wine 1 to 2 nights a week. She used to be a smoker with a 10-pack per year history and denies any illicit substance abuse. She has drug allergies to amoxicillin, which caused nausea, and codeine, which caused her to pass out. Her pre-transplant med list includes aspirin, atorvastatin, calcitrol, carvedilol, vitamin D, clopidogrel, Ranavite, hydralazine, and basal bolus insulin. Her post-transplant med list includes tacrolimus, Cellcept, prednisone, valganciclovir, Bactrim single-strength, nystatin, famotidine, carvedilol, atorvastatin, clopidogrel, aspirin, and basal bolus insulin. Her blood pressure today was 158/78, and she had a heart rate of 75. Her pain score was 3 of 10, and her serum creatinine was 1.0 with a creatinine clearance of 74. Some other pertinent lab information from today's visit includes her glucose being 138, her BUN is 25, her white blood cell count is 4.7, her platelets are at 145, and her tacrolimus level is 6.4, and that's the 13-hour level. Some information about her donor: he was a 40-year-old male who died secondary to CVA and stroke with a terminal serum creatinine of 0.9. The KDPI was 35%, and there are no growths on the culture, and it was a 0 to 1 to 1 mismatch. The CMV donor is positive, recipient negative. The PRA class 1 is 52%, and the class 2 is 99%. Cold ischemia time was 18 hours and 2 minutes, and revascularization was 40 minutes. So our assessment and plan for this patient for her transplant maintenance: she's currently taking tacrolimus 5 milligrams twice a day with a tropical of 7 to 10 nanograms per milliliter for the first 6 months, Cellcept 1,000 milligrams twice a day, and prednisone 45 milligrams once a day. Her brother states she's been having excessive diarrhea and discomfort, which may be due to the Cellcept. So our goals for the patient is to prevent rejection and minimize any side effects. So our plan is to increase tacrolimus to 5.5 milligrams twice a day and switch the Cellcept to Myfortic to 720 milligrams twice a day. We're going to want to monitor any signs of rejection and any side effects, including blood pressure, blood sugar, neurotoxicity, or any headaches or tremor that could occur. We also counseled the patient to avoid taking any type of NSAIDs for her headaches and to recommend that the patient takes Tylenol. And we also counseled to take the famotidine 2 hours separately from the immunosuppressants. For opportunistic infections, she's currently taking valganciclovir 400 milligrams Monday, Wednesday, and Friday for CMV prophylaxis, Bactrim single strength Monday, Wednesday, Friday, and nystatin suspension. So goals are to prevent any type of infection and to reduce any side effects that could occur with the medication. So our plan is to increase the valganciclovir dose to 900 milligrams daily and to increase the frequency of the Bactrim single strength to once a day. We'll want to monitor for any signs and symptoms of infection, including fever and any side effects such as leukopenia. For her hypertension, the patient currently has a blood pressure of 158/78 and a heart rate of 75. She currently takes carvedilol 25 milligrams twice a day. Per the KDIGO guidelines, the blood pressure goal is less than 130/80. We recommend continuing the carvedilol 25 milligrams twice a day and starting amlodipine 5 milligrams once a day. If the patient's still uncontrolled after that, we can increase the dose to 10 milligrams once a day, and we'll continue to monitor her blood pressure daily. For her diabetes, she currently has a fasting glucose of 138. She takes prednisone and tacrolimus, which could cause insulin resistance and impaired sensitivity secretion. She was taking basal and bolus insulin, so our goals of therapy per ADA is to have a fasting blood glucose of less than 126. So our plan is to continue her basal and bolus insulin and add on linagliptin 5 milligrams once a day. We'll monitor her blood sugar levels daily and her A1C levels every 3 months. We'll want to monitor for any signs of symptoms of worsening diabetic complications like peripheral neuropathy, retinopathy, and nephropathy. The patient's brother also stated that the patient was taking fluoxetine but did stop taking this, so we recommend that she follow up with her primary care physician before starting any new medications. Thank you for the consult. Please let us know if you have any other questions. Thank you.